Okay, here we go. Here's the big one. This one might be the longest one of the entire course. I talk fast, but we want to make sure that we get this. You may want to watch this a couple times. Be careful that you don't get confused on this, and be sure that you're using your A4L and working through on these AV blocks. Okay, so what is an AV block? It's some sort of conduction delay in the AV node and AV junction area. What causes it? The same stuff that we've talked about causing conduction defects, ischemia. Maybe it's just an old age disease process. It might be meds or other or drugs, other bad things you put in your body. Could be electrolyte imbalances. Are they always bad? Well, no. Sometimes we need an AV block. It's a physiologic block. That's a good thing, such as atrial flutter. Atrial flutter, if it's at 1-to-1 conduction, in other words, if every flutter wave is allowed to get through the AV node, then that's atrial chaos becoming ventricular chaos. The AV node's not doing its thing. So the AV node is supposed to block sometimes to keep those crazy fast atrial rates from upsetting the ventricles and causing VFib. Sometimes an extra beat shows up very early. A PAC comes along and the AV node is not ready. It says there's no reason for this, we don't need to do this, and it just stops that premature atrial complex and you get a non-conducted PAC. That's a physiologic AV block. It's a good thing. It's trying to keep the rhythm regular. It's trying to keep the rates under control. So the AV node really likes to keep the rate at less than that 140 or 150 threshold, and it does that by blocking impulses. So sometimes an AV block is good. It's a physiologic block. First degree AV block we talked about way back in the PRI, because that's how you determine it. The PRI is too long. It's more than 200 milliseconds, more than 5 little boxes. And so first degree AV block has no dropped beats. No drop beats. There is one P wave for every QRS. The conduction ratio is 1-to-1. Now, you can have a first degree AV block along with some of these others with a second degree AV block. And so now you have a long PRI and some dropped beats in the second degree. And we just usually just say it's a second degree block. I don't want you to think that first degree is no big deal, because first degree indicates some sort of conduction defect, and that whatever's causing that can continue to cause bigger and bigger problems. So it's not about severity. It's just a name. They could have called it a type 1 block, or they could have called it a blue block or a zebra block. They could have named it anything they wanted. They called it first degree, and that tends to make you think that somehow third degree is more deadly than second degree. And so at any rate, severity and the degrees are not really related. First degree AV block could be caused by meds. People that take digitalis, digoxin, lanoxin is one of the trade names. It's very commonly used a lot in the past. Patients are still on it. Dig comes from the foxglove plant. It's a controlled poisoning of your cardiac cells. So just the right amount works great, but too little can be a problem and too much can be a problem. And so first degree block, AV block, can be caused by dig. First degree AV block can also come with an inferior wall MI. Somewhere between 10 and 15% of the time when you have an inferior wall MI, you're going to have some first degree block. And that sort of makes sense once you figure out where that wall is, that inferior wall of the left ventricle is, and what artery feeds it, and then look at what else that artery feeds. So it turns out the right coronary artery feeds the inferior wall most of the time, and it also feeds the AV node. So it just makes sense that there's some sort of disease process in that right coronary that's causing you an inferior wall MI. You could also have some AV nodal problems. And so again, it may progress. Don't be fooled by the degree. The severity and the degree really have very little to do with each other. And this is a nodal block. Why do we care? Because if we're going to deal with the block and fix it, we need to know if it is happening in the node or below the node. The parasympathetic nervous system innervates the node, but not things below the node. So nodal blocks can be attacked by dealing with the parasympathetic system, taking off the brakes. Otherwise, if it's an infranodal block, you can mess with the parasympathetic system all you want. The brakes aren't the issue. We're going to have to step on the gas. You know, that'll make more sense to you once we get into the face-to-face class and we do some sim sessions. Here's some example of first degree AV block. All it is a prolonged PRI. It's more than 200 milliseconds. It's more than one big box, more than 5 little boxes. That's it. Very simple, very straightforward. Second degree, there's several types of second degree. There's type 1, there's type 2, there's 2 to 1, and there's high grade. So this is the first of those, a second degree type 1. And we can't seem to name things just one thing in medicine. We have to name it 2 or 3 things. And that happens in the pharmacology world as well. And here it is for sure. We have a second degree type 1 AV block. That's good enough. But somebody also wants to call it Mobitz 1. Okay. And then there's somebody else wants to call it a Winky Bach. Not Winky Block, Winky Bach. Okay, cool. I think Winky Bach's kind of a fun word. I'd like to name a cat Winky Bach. But it's second degree type 1 that also has 2 other names. Here is the key thing with second degree type 1. The PRI lengthens before you drop a beat. And there's only one beat that's dropped. So you have a ratio of P's to QRS's that's very close. It's 3 to 2, 4 to 3, 5 to 4, 6 to 5, 7 to 6. More commonly 3 to 2, 4 to 3. But you can have 5 to 4, 6 to 5, whatever. It's a one-run game. The score is the P's are winning by 1 run. And that's it. I'm sorry. That's it. So the PRI is getting longer and longer and longer. Or longer, 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 longer. It's going, going, gone, or going, 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 gone, whatever, but the PRI is getting longer. When we look at type 2s here in a second, you will see the PRI is not changing. So both of them have dropped beats, but it's all about the PRI. So Mobitz 1, what causes that? It could be meds. DIG again is a common cause. Could be an inferior MI for the very same reasons. It's a nodal block. It's in the AV node. Where's the blood supply come from for the AV node? The right coronary. What wall does the right coronary feed? The inferior wall. So inferior MIs, inferior STEMIs, may also have AV block issues, conduction defects in the AV node. Hey, so this may be no big deal. It may indicate that there's a disease process or ischemia going on in the conduction system that may get worse. But usually type 1s don't require much treatment because there's enough impulses getting through. As long as you have, if there's 7 or 8 P waves and 6 or 7 of them are getting through, then the ventricular rate's okay. Remember, the rhythm is not the problem. It's the rate that results from the rhythm disturbance. That's the problem. So type 1 is a nodal block. First degree is a nodal block. Here's some examples of type 1. The hallmark again is that there is a dropped beat. And if you look right before that dropped beat, you'll see a very long PRI. You look right after that dropped beat, you'll see a very short PRI. And then if you look back through and watch, each PRI gets longer, 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 and then it drops. Or longer, longer drops, or longer, 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 longer drops. The ratio can change, but the PRI needs to be getting longer every time. Second degree, type 1, Winky Bach or Mobitz 1. It's got 3 names, it must be cool. Second degree type 2s. These are infranodal. These are not in the node. So you can mess with the AV node via the parasympathetic nervous system all you want. You can give this patient buckets full of atropine to block that parasympathetic side. It's going to do not one single thing for a second degree type 2. This block is below the node. It's in the His bundle or it's below that. It's not the right coronary. It's the left coronary artery. These go along with anterior MIs. These patients are usually symptomatic or they're going to be symptomatic, and this usually progresses to worseness, complete badness, a complete AV block. So second degree type 2s are worrisome. Now, it may have a narrow QRS or a wide QRS. Who knows? Who cares? But there are dropped beats. There are P waves that don't conduct, and the PRI is constant before the dropped beat. Mobitz 1, PRI is lengthening, Mobit's 2, the PRI is constant. But again, there's only one beat that's dropped. It's still a one-run game. And the whole deal here is how many are getting through. Is that making a decent enough rate? So ratio is going to be 3 to 2, 4 to 3, 5 to 4, something where there's just one more P than a QRS. We're only dropping one P wave. And when you look at that dropped beat, then you see that the PRI is constant. Now here's a good long screen, and those of you that are fire service instructors are freaking out because I have completely violated the maximum number of words on a PowerPoint slide, and I'm just not worried about it because you're going to get this in a PDF. You can read this over and over. This is good stuff, and just explains, in essence, these people are sick, and second degree type 2s should bother you. They should worry you because they can become a complete heart block, and sometimes the amount of P waves getting through, the resulting ventricular rate is not good enough to keep things going. Here's a second degree type 2. You notice a dropped beat. March out the P's. So is the rate okay? Well, probably. What are the P waves doing? March out the P's. Are the atria making a regular rhythm? And they are. If you use your field calipers, you will find that those P waves march out all the way across there. It's just that one of them doesn't produce a QRS. And so you look at that dropped beat, and you look backwards and you see a PRI, and you look forwards and you see a PRI, and they're the same. If this were a type 1, right there at the dropped beat, you would look backwards and see a long PRI, look forwards and see a short, or see a normal PRI, a much shorter PRI, and you look at all the PRIs and they're lengthening, and you say, okay, that's type 1. Type 1 can progress to type 2, but type 2 can be bad all on its own and go to a third degree in a pretty big hurry. There's a special case where the conduction ratio is 2 to 1. And this is second degree AV block with 2 to 1 conduction. That's its name. It's not type 1, it's not type 2, it's second degree AV block with 2 to 1 conduction. There's only one PRI before that dropped beat. So when you look back at it, you can't really tell whether it's getting longer or not because it's only there once. So it's a 2 to 1. And here's an example of that. March out the P waves. What are the P waves doing? The P waves are marching right through there. They're coming in on time. They all look the same. There's none that are early. It's not a non-conductive PAC. It is a standard sinus rhythm, but it has a second degree AV block with 2 to 1 conduction. And that's all you can say. Here's another one, and this one tends to get a little confusing. There's some misinformation out there amongst some preceptors, at least in our system. A second degree high grade AV block. A high grade AV block. Up until now, we've said the ratio in second degree, type 1, type 2, or 2 to 1. The ratio is one more P than QRS. There's only one beat that's dropped. But in high grade AV block, there's more than one beat that's dropped. The score is 3 to 1, 4 to 1, 5 to 1. There's lots of P waves and not many QRS's. This game is not close. The P waves are winning big time. So a ratio of 3 to 1, 4 to 1, 5 to 1, think about that. Unless that atrial rate is really high and you have a 4 to 1 conduction ratio, your ventricular rate's going to be really slow. So second degree high grade AV block can be a problem because the resulting ventricular rate is just too slow to maintain decent cardiac output. Blood pressure drops, patient falls on the floor and tries to die. So this is not a third degree AV block. Those are not synonymous terms. There's some folks out there saying that a high grade AV block is a third degree or second degree type 2. No, 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 no. High grade AV block is its own specific rhythm. And here's an example. Look at all the P waves. March out the P's. What's the rate? Well, the rate's bad. Look at that. There's 3 complexes on each of those strips in a 6-second strip. That ain't going to work. That's not a good enough rate to keep cardiac output up. The stroke volume would have to be tremendously high because it isn't beating very often. And it's just not going to work that way. And so this person's going to have a rate problem. Then you look, is there a P for every QRS, a QRS for every P? No. What are the P's doing? Well, I march it out with my calipers. Yep, the P's are coming in on time. None of them are early or weird looking. So it's not a PAC. It is a whole bunch of P waves, not many QRS's. This is not third degree block. There is a relationship between some of the P's and a QRS. In third degree block, there would be no relationship. So I don't think this is very common, but it is out there and it's something to think about. Now, finally, third degree AV block. Third degree AV block is complete AV block. There is AV dissociation that must be present. Whatever's going on with the P waves has nothing to do with whatever's going on with the QRS's. The P waves are not causing the QRS's. The P waves march out at a nice regular rhythm, so do the QRS's, but that's a different rhythm. This is two different drummers playing at the same time, and one's not keying off the other one. There's no correlation between the two of them. And so you have the P waves at their own rate, and no one really cares what that rate is because it's the ventricular rate that matters. Some examples of this, a couple of folks had talked about the windshield wipers on their old school bus or on the old fire trucks, where the right wiper does whatever it wants and the left wiper does whatever it wants, and they're not in sync in any way, shape, or form. Now, technically, there's no PRI. But when you look at it, your eye sees a space between a P wave and a QRS. And so you call it, your eye and your brain calls it a PRI, but you realize that eventually, no, those P's aren't related to the QRS's. Anyway, the space is changing. So what looks like a PRI is not only not constant, so it can't be second degree type 2, and it's not lengthening, so it can't be second degree type 1, but you can confuse third degree AV block with second degree type 1. That's an easy mistake to make unless you're being disciplined about this. Technically, there's no drop beats, but it may look like that there are. So, of all the AV blocks, the only one that has dropped beats are the second degrees. The first degrees just have a long PRI. The third degrees don't have any PRI. There's no relationship. There's AV dissociation. But the second degrees, there's dropped beats. One last note about AV dissociation. You may have recall hearing this before. The question is, can there be P waves in VTAC? The answer is there can be, but they must be dissociated. And that's the same thing that's going on here. The atrial activity has nothing to do with the ventricular activity. Where does that show up? That characteristic of AV dissociation? It shows up in third degree AV block, and it shows up in VTAC. Example of third degree block, take a peek, look closely, look at the P waves, march them out. They fall in a nice regular order. None of them are early, none of them are funny looking, they're all sinus. That is a sinus rhythm. Those are sinus P waves. That is a sinus rhythm with third degree AV block. Several different examples there. The QRS will tend to be, almost always is, wide because it's a ventricular escape rhythm that's coming in there. The SA node impulse did not make it through the AV node. The AV node wasn't firing, and the ventricles said, look, we ain't going to a funeral today, and they're going to escape that by generating a beat. So the ventricular escape rhythm pops in. That's third degree AV block. Okay, now going back to this whole concept of the junction. The junction. The AV node is not the same thing as the AV junction. The junction is a large area. The AV node is contained in it. There's AV Junction County, and inside that is the city of AV node. Okay, and so here you have geographically what's going on with the AV node and then the bundle of His. That is the junction, and then the branches come off that bundle. Just wanted to throw that in because it matters whether the block is in the node or below the node. And then here we have this degree versus severity. I mentioned that before. Wish we'd named it something else, but they started calling it first degree and second degree. And really, second degree can be just as bad or even worse than a third degree. The location of the block is a bigger deal than the degree of the block. Nodal blocks are one thing. Infranodal blocks are another thing, a little more scary. Think about why this block is happening. Why is there this conduction defect? Well, the right coronary artery may be in trouble, and almost all the time that's what feeds the AV node. Or it could be that the left coronary artery is in trouble, and that's what's feeding the bundle branches. So right coronary artery, AV node blood supply problems, parasympathetic nervous system can work on that. It does innervate the AV node. But if it's not, if it's infranodal, if that block is below the AV node, then it's not about the parasympathetic system. Put down your atropine. It's not about the right coronary. It's all about the left coronary artery, and you can squirt atropine in their ear and have as much impact as you're going to have by giving it in the IV. Conduction system innervation, again, same thing I was just talking about. That SA node and AV node have parasympathetic nervous system innervation. The vagus nerve does transmit to them, and so something that blocks the vagus nerve, like atropine, one of our favorite meds, works great as long as the issue's in the node. If it's below the node, atropine's not going to make any difference. Okay? And so again, we keep hammering this point, but it's really important that we understand this. When you look at the ACLS poster for symptomatic bradycardias, it says, if atropine ineffective. It's not a complete sentence. It's missing some words. It doesn't say if atropine has been tried and it's ineffective, or if atropine can be predicted to be ineffective. It doesn't say that. It just says if atropine ineffective. So you have to navigate through that and figure out what you're going to do. And there's just really no sense in giving atropine, a parasympathetic blocker, to a block that's not being caused by something innervated by the parasympathetic system. And so this may be a little confusing now. We wanted to front load you with all this. We'll talk about it a lot more when we do sim stuff. But here you go. Here it is. What blocks are in the node and what blocks are infranodal, below the node. Second degree type 2 and third degree blocks below the node. And so, you know, you're not going to get a heck of a lot of use out of atropine in that case. The first degree and second degree type 1s and some complete heart blocks come from the node. So sometimes that complete block is going to be something that atropine will work on. Sometimes. But second degree type 2, nope, those are all infranodal. Those are in the bundle or below. And then complete heart blocks, or which third degree AV blocks, those can be nodal or infranodal. So the takeaway on this from a treatment perspective is, yeah, it's okay to try atropine on a first degree, on a second degree type 1, or on a third degree. It's just plain silly to try it on what you know is a second degree type 2. Here it is again, infranodal and nodal blocks. Good for you to check this out on the PDF. This screencast is getting kind of long. I don't want to give anybody a migraine or something. So you can look at this on your own and go through. But it's location, location, location. The QRS width does not always tip you off. And so you'll get that old crusty medic out there that says, oh, that's a narrow QRS. That's got to be a second degree type 1. And so you can say, okay, thanks. But you got to think about this and look at this. And that QRS width's got nothing to do with where that AV block is. The QRS can be wide because it's ventricular escape or because there's a bundle branch block. It's got nothing to do with that. But you'll hear people say that. So it's not a hard and fast rule. It just seems to work out to where those blocks that are nodal usually have a narrow QRS, but not always. And those that are infranodal have a wide QRS, but not always. So I guess what I'm saying is when you see dropped beats and a wide QRS, get worried, believe it's a second degree type 2, and then go about analyzing that to prove yourself right or wrong. But get concerned with dropped beats and wide QRSs. Talked about it a couple of times. I want to re-emphasize this. We're going to move on here in a couple lessons to STEMI identification. And STEMI seems to be the only thing anybody cares about once they learn about it. They just forget about conduction systems, forget about rates and measurements and all this other stuff. But here's the big deal. When you find an inferior wall STEMI, look for problems in the node. Be ready for those patients to be bradycardic and develop first degree, second degree type 1, or complete heart block. When it's an infranodal, those tend to go along with the anterior MI. So you see an anterior STEMI, think, you know what, this could turn into second degree type 2 or complete heart block. I need to watch for that. It's the ratio of P's to QRS's. Remember that the only time that the score is more than a one-run game is in high-grade AV block, meaning that the others, second degree type 1, second degree type 2, second degree 2 to 1, and complete heart block, you typically have just one more P than you do a QRS, but that high grade you have a lot more. Very first step when you see drop beats is make sure it's not a PAC. Is that P wave right before the drop? Is that P wave, did it come early? So march out the P's. Did that dropped P wave come early, and is it weird looking compared to the other P's? If it came on time, it's not a PAC. If it came early and it's weird looking, it is a PAC. So if that wasn't a PAC that caused it, if the P wave came on time and looked just like the others, it's some kind of second degree AV block. That's just all there is to it. I would really like to have a 6-foot strip, not a 6-second strip. A 12 lead's only 10 seconds long. When I'm trying to look at AV blocks, I don't need 12 leads. I need 12 foot of EKG paper. And the managers, your managers may freak out when I say this, but that's just EKG paper. That's pretty cheap. They'll buy some more. Hey, you're going to be new medics. New medics are supposed to walk around with EKGs wrapped around their neck and dangling off their foot like toilet paper. You're supposed to run great big long strips. You're supposed to show everybody your first SVT that you converted with adenosine like you just birthed a baby or something. You're supposed to be freaky geeks about this. So print out great big long strips. That's why the bench seat in the ambulance is so long as it is. That's so you can lay that EKG strip on it. Use those big old long strips. You don't need more leads, you need more paper. So that is what will help you the most with AV blocks. And so here's the AV block poem. I'm not really into poems. I really don't think that's a very good image, but whatever, you can Google for this if you're really interested in it. There's all kinds of dances. There's all kinds of sayings. I don't know. I just kind of like to understand it. But I don't really care how you learn it as long as you learn it. Mrs. Smith needs you to know this stuff. How you get there is not the important thing. It's the outcome we're looking for. AV blocks can be a big deal. Last couple of thoughts here. AV nodal blocks tend to come and go. If you get rid of the ischemia, or the cocaine wears off, or the DIG wears off, or the electrolytes get corrected, when you fix the cause of those AV nodal blocks, meaning type first degree or type 1s or some third degrees, you get rid of the cause, the block goes away. It's the ones below the node, those tend to be more serious and more permanent, and that is either significant ischemia or it is a pretty bad disease process of the conduction system. So the scarier blocks, the infranodal blocks, they're the scarier ones, and they don't go away as easy even if you fix the cause. Here's a complete AV block, kind of a summary here toward the end. I see a high-grade block down there. See all kinds of scary things that can happen. And so in every case, how do you attack these? You march out the P waves. March out the P waves. What's the ventricular rates? The first thing, is there a P for every QRS? Well, obviously not. There's dropped beats. What are the P waves doing? What is the atria doing? March it out, look at it, and then compare it to what's going on with the ventricles. Another big long slide. Got a lot of good information. I won't read this to you. This has gotten longer than I really wanted it to be. But like I told you, AV blocks is a big topic. Causes a lot of heartburn for medic students. And so we really wanted to give you as much information, all vetted from reliable sources as we could. And I think this is it. This is the last screen. Here's a decent chart. I would think that a good way to learn AV blocks would be for you to be able to draw this chart from scratch. And so flashcard each one of these little cells on this chart and just be able to reproduce this thing and just quiz yourself, write down describe in words each of these blocks, draw pictures of them, and be able to describe these various characteristics of the different AV blocks. You're probably going to want to watch this one again a couple times. Definitely do the A for L on this one. It's a long one. And really dig into this AV block thing, because you can overcome this. You can master this. It's not that hard, but it is a little confusing. The terminology is not straightforward, and it's all probably new to you. So AV blocks, that's it.